Here we are. Welcome to London, guys. Welcome to London.
Thank you, Lorenzo, for the invitation to be here. I'm very excited to talk about now the post-operative evaluation using a tool that's widely available to us, which is ultrasound. We usually have them not only perioperatively, but in the cath lab as well. So I'm going to just follow up with why ultrasound is so important in the post-operative space. We can use direct interrogation of the pedal arch. So I'm not only looking at TCPO2, we're looking at pedal acceleration time, which is a measurement of perfusion, and it is objective. You can see these waveforms here. This is the medial calcaneal branch to a heel wound. We can get that granular in looking at perfusion to these wound beds, and it's very important because we want to get our patients to the point of wound healing and amputation prevention. And this is the patient, who underwent a procedure, endovascular revascularization, all the way to wound healing. And we're following that patient throughout the course of wound healing, looking at these small vessels below the ankle. We now have a defined metric. We know an endpoint. Based on our publication on the Annals of Vascular Surgery, the pedal acceleration time, which is the measurement of the rise time of the arterial waveform, has to be less than 180 milliseconds. Class 1 or Class 2 PAT. And this is really important because not only do we have an objective number for wound healing, we also have an endpoint on the table during intervention to where we can say we have restored enough blood flow to that wound bed. So pedal acceleration time is far beyond just this metric. We can look at anatomy and flow hemodynamics around the pedal arch. Very important in the setting of indirect revascularization to the wound bed. And this criteria has been published in the Annals of Vascular Surgery. So PAT is broken up into 4 classifications. Class 1 being normal, all the way to Class 4 being consistent with tissue loss and rest pain. And again, we want the PAT to be either Class 1 or Class 2 to indicate wound healing. And this is just the extension of the arterial duplex. We're just scanning below the level of the ankle on the anterior and posterior circulation of the foot. And I can't hold back, Lorenzo. I have to add in just a little bit of the preoperative ultrasound because this gives you a target artery pathway, basically an ultrasound roadmap. We used to stop scanning at the level of the ankle, and who wouldn't want to know what's happening in the pedal arch? Because in this situation, his first dorsal metatarsal artery is occluded, and we're just going to have to get flow through the second dorsal metatarsal artery going to that great toe wound. And I would be remiss if I didn't talk about intraoperative ultrasound. We use EVIS as well. I appreciate your comments. But we also use on-the-table PAT during an intervention. We can see flow during every intervention at an interventional stage, and then on the table 1 hour post-operative. And we can also detect emboli with atherectomy. Very important. It's very exciting space. And of course, Lorenzo is all about the woundosome, and I am about the PAT. So together we're quite a pair. So this is a great example of a patient that I just saw last week. Previously did his SFA stenting. You can see, like, what would you use for this patient? He can't do a TBI, of course. We can use TCPO2. Yeah, we could do ABIs, but we really want to know what the status of the pedal arch is to this wound. So obviously it is Class 4. This is, he needs to be revascularized. He's got 2-vessel runoff, but he also has a nice great saphenous vein, distal target for distal pedal bypass. So we can plan a lot and understand, for further treatment of the care of these patients. And I love it for surveillance. Sometimes you get lucky. This guy showed up with just a little tiny wound on the bottom of his foot. We have a nice relationship with our podiatric partners, and look, he's got Class 4 PAT. We caught it early enough that now the wound doesn't progress. So if anybody watched the pedal acceleration time workshop, we brought in Lorenzo's patient with a TMA. It took 5 seconds to look at the arcuate artery and understand perfusion. It's quick, it's easy, and it's low cost. So this is direct interrogation of the pedal arch, and there is a method to this. It's very, very simple. So I encourage you to learn this technique and employ it into your practice. Even if the vascular scientists don't do it, physicians are learning all around the world, and patients need this. They deserve a higher level of scanning. And we can see, when you see this angiographically, we know that well, you can't really say what the objective perfusion is like, but when we put on a pedal acceleration time, we can. And we can see these communicating arteries with duplex ultrasound and really help define and understand the hemodynamic pattern, especially in the setting of single vessel runoff via the perineal artery. So you can see we saw the posterior communicating artery, here's the anterior communicating artery, and once you understand that communication flow around the communicating arteries, it helps provide insight to the pedal arch flow, which is very helpful in the setting of complex patients like this, or when we have to indirectly get flow to that wound bed. So we often have conversation when Lorenzo and I about, does PAT hold true throughout the course of time? And the answer is yes, unless there's an interval change like an occlusion or a high-grade lesion or vessel recoil, PAT stays true over time.
That's something that for me it's important, because many times we see, oh, we do an angioplasty and then, it will develop more collaterals, or we do, we think that things change, but actually your data are saying the opposite. So essentially, whatever I achieve on the table, I can't expect at the level of the wound much more to happen after 2 months. Am I right?
Yep.
Of course, saying that the vessel stays patent. Of course, if the vessel goes down, we achieve less. But it's not going to be all this recruiting that we think about or we talk about. I don't know how much true is in there, and actually you're telling me that with the PAT, even if you recognize a vessel, which is fantastic, at the level of the wound, the perfusion doesn't increase apart from the initial peak. It doesn't grow up 30% in 2 months, am I right?
Yes, it stays consistent. And this is a great example. This patient has an occluded PT lateral plantar. Maybe people would have done a DVA on this patient, but we're really getting granular and looking at the collateral pathway off the perineal artery to the calcaneal branch to the heel wound, and it was quite successful. Sorry for the slide. So anyway, there's consistency of PAT over time. I would be remiss if I also didn't talk about pedal arch scanning of the veins preoperatively for DVA. So we can see these veins really, really well. We can appreciate the valves and have an understanding of the diameter and the health pre-DVA. So here's an example of an occluded lateral plantar artery. It's a beautiful, healthy lateral plantar vein for possible access. So I think there's a lot of excitement around DVA, but ultrasound is vital, not only in the preoperative, but certainly post-operative too, and we can help aid with operative success, as you see Dr. Montero accessing that lateral plantar vein. So, sorry, sometimes my slides didn't come up here, but when we assess the DVA post-operatively, I think a lot of people are looking at just flow volumes, and we've discovered that we can look at other hemodynamic metrics in the foot. So we are looking at venous pedal acceleration time, so looking at the rise time of the now arterialized flow in the lateral plantar vein. Very helpful because it tells you if you have an inflow issue. We can look at resistive index that tells us what's happening distally, and then we look for a new metric called conversion. So this is really exciting. This is the use of duplex ultrasound. This patient had a DVA open for about 5 months, and of course it went down. And this is looking at the superficial arterialized pedal venous flow with duplex ultrasound. This patient has converted, and this means that this patient has enough unnamed arterial flow to the wound bed. Look at this tissue granulation. The venous PAT is class 1. And you can see the rise time of the waveform.
And is the venous PAT the same as arterial PAT? So do you consider the same values? Do you have the same metrics, or is it different like the classes that you showed? Is it the same?
For now, yes, it's the same, but there's a whole lot of research that needs to be done for sure. But right now we're applying the same value. Again, more examples of really nice acceleration time, and resistive index is very low in the setting of an occluded DVA, and this patient went on to heal quite nicely. So I think, in summary, thank you very much. I think ultrasound plays a vital role in the perioperative care of these CLTI patients, and thank you for having me, Lorenzo.
Thank you so much, Jill. Thank you. Is there any question? Jill.
I have an excellent presentation, and I have two questions. The first question, is this method biased during the intervention from the location of the seeds, from the time after angioplasty, or you can find directly an association between, opening of the vessel and increase of or decrease of the acceleration time?
It's on the table real time.
Real time. So if you have the seed inside the SFA and then you're removing back, do you see a change? So
Yeah.
that's the point. I mean, when are you ready to say, okay, now you have reached the time that you want? You're removing the seed, you are waiting for a few minutes.
Okay.
What is your...
Yes, thank you for asking that. Someone asked in the workshop too. So what we're learning too, especially with like antegrade access, so if you have a great toe wound, you'll take a pre-PAT in the dorsal metatarsal artery without the sheath in place. Let's say it's 200. Now you access and have your sheath, and you have to take a new PAT because this is occlusive. So now you have to take into account that delta of change, and what will happen is you'll see an increase depending on the vessel size, maybe 30 points. So now you have a new metric to work with. So if you then do your intervention and you get your PAT down to 150, you know it's going to decrease by 30 once you remove the sheath. Yep.
Very interesting. So, Conrad and Professor Salo, and then we're going to go for our coffee break.
Yeah.
Okay, you
Yes,
start.
one quick question. Very interesting, but we are interested also in morphology for scientific studies, for example. Do you think that it's possible with duplex ultrasound to see the lumen gain or the lumen over the time once we have recanalized the below the knee or the above the knee, the ankle arteries or the pedal?
I think it is it's case by case basis on how well we can see. So we're trying to do a lot of work intraoperatively to see those changes real time. Of course, there are patients where we can't see very well. I also like the use of ultrasound with flow limiting dissections. I mean, IVUS is obviously a fantastic complement. I feel like I'm always trying to beat it or make it better, but the reality is that we're still learning a lot about extravascular ultrasound, and I think it's promising, especially with how well the imaging is today.
Conrad?
Professor, it's a very valid point, and I believe in both techniques, IVUS and EVUS. Just 2 points. The Dolphin study was showing the mean vessel area improvement in IVUS imaging. I think that's a really interesting new granular metric from IVUS, which is looking at, for the BTK, how much bigger are we making the lumen, and does that correlate with outcome? So that's something which I think IVUS probably wins that one. And in terms of a very practical step, I've read your paper, it's brilliant, and thank you. You're a hero for us radiologists trying to do stuff with the ultrasound probe. But my one tip is do it before you take the sheath out, because when you do the PAT whilst you're pressing on the groin, you get really crap pictures.
Yes.
And even afterwards. And I was trying to work out, why is it even now class 4? But I did such a great job.
And they're compressing.
It's also
And then my
difficult.
reg said, I think you're pressing too hard.
If you remove the sheet, it's also difficult then to improve the flow.
Exactly. So it's just getting the timing right. But thank you, Jill. It's
Okay,
amazing
thank you,
topic.
Jill, so
Thank
much.
you.
It was wonderful.